Very good afternoon to all of you. Today I am here with a very interesting case of choroidal osteoma with secondary choroidal neovascularization, a case report. Our case is a 37-year-old female who came with chief complaints of diminution of her vision in both her eyes for last 8 months. Her diminution of vision started in her right eye first, followed by the left eye over a period of 2 to 3 months. It was painless, gradual, progressive, and was associated with distortion of images. There were no history of redness or photophobia or trauma. The past history, family history, and personal history were not significant, and she belonged to a lower middle class. On ocular examination, visual acuity in both her eyes were 6 by 60, which was best correcting to 636 in her right eye and to 612 in her left eye. Rest of the anterior segment findings were within normal limit, including the intraocular pressure, which was normal in both the eyes. On fundus examination, in both the eyes, there were adjacent to disc, there were yellowish to orange-red lesion, subretinal lesion, which had a geographic border, and it was slightly elevated with vascular branching over the lesion with some pigmentary changes. There were also grayish patch over the macula. With all these, the differentials we kept as were choroidal osteoma, choroidal melanoma, choroidal metastasis, choroidal hemangioma, and posterior scleritis. To streamline our diagnosis, we did certain routine investigation like complete blood count, random blood sugar, lipid profile, serum calcium, and serum alkaline phosphatase, which all came within normal limits. On OCT macular examination, there were subretinal hyperreflective lesions along with subretinal fluid in the right eye, and there was no subretinal fluid in the left eye. But there was a breach in the RPE Brooks membrane area. On fundus fluorescence examination, it showed early hyperfluorescence and late leakage and staining in both the eyes. On B scan, there was a flat choroidal lesion with very high reflectivity and acoustic shadowing, giving a pseudo-optic nerve sign in both the eyes. With all these, we came to a diagnosis of choroidal osteoma with secondary choroidal neovascularization in both the eyes. For treatment, we started her on anti-VEGF bevacizumab in her right eye, and for left eye, we kept her on observation. On subsequent follow-up, there was regression of the choroidal neovascular membrane along with the resorption of the subretinal fluid. We did follow-up over a period of 6 months, and after giving 3 intravitreal injections of anti-VEGF bevacizumab in her right eye, the best corrected visual acuity was 6 by 12 in her right eye, and there was no progression of lesion in the left eye. And we saw regression of choroidal neovascularization and subretinal fluid in the right eye. Coming to discussion, choroidal osteoma is a rare benign ossifying tumor of unknown etiology. It typically presents as unilateral lesion. It is more common in healthy young females in their second and third decade of life. It is usually located in the peripapillary and juxtapapillary region and may extend to the macula. Most common complication of this being the choroidal neovascularization. In treatment modalities, the treatment is mainly directed towards the complication arising out of it. That includes anti-VEGF treatment, laser photocoagulation, and photodynamic therapy. To conclude, choroidal osteoma is a rare tumor but has got vision-threatening complications. Hence, early diagnosis of these complications and timely intervention can help prevent significant visual morbidity. These are all my references. Thank you.
Thank you so much, Dr. Anupama.
You could do an CT scan and it will show brilliantly the bone lesion.
Yes.